course, now trying to guide people who are listening to this program, saying, well, you could use anything, give me some guidance.
Could I just mention alemtuzumab, where the recommendation has been it's a third-line agent, that you try at least 2 others. But if you hark back to the phase 2 CAMS 223 trial, they had great data. They had wonderful data using it in treatment-naive patients. And I might imagine a rare case where someone really wanted an induction long-lasting agent and a potent agent and was willing to take some of the risks, even in a treatment-naive. So I might rarely use it in a treatment-naive. And I'm telling you, CAMS 223, those patients did very well.
And you raise an important concept, which is the prospect of durable treatment effect. Because this is something that I think is not just a quantitative difference between treatments, but a potential qualitative difference between treatments. And so with alemtuzumab, one of the observations had been is that after a couple of courses of treatment, and sometimes with a third, you may get several years with no evidence of any clinical or imaging disease activity. And if that indeed reflects a durable capacity through this concept of changing the immune system so that the new immune system that comes back is importantly different. This is a concept that I think many patients will embrace some upfront risks more readily. I think with alemtuzumab, what we've seen, though, is even more risks associated with it, some of them very serious, which is why I'm somewhat more lukewarm about starting it, although one would certainly consider it still in the armamentarium.
So should we be looking at more withdrawal studies? Because immunologically, one can think of things like B-cell depleters, and so what's coming back, right? And it may be that what's coming back initially, at least, may be good for you.
Well, there's good biological evidence that the B cells that come back after anti-CD20, the doses that are used in the clinic, are not biologically the same as they were there initially. At the very least, when you treat people in their 20s, 30s, 40s, there will be a proportion of naive B cells and a proportion of memory B cells. The ones that come back are almost all naive as opposed to memory. And we think as far as the role that B cells play in driving aspects of the T cell response that is thought to underlie the relapse biology, that it is within the memory B cell pool that those overly pro-inflammatory B cells may exist driving the T cell responses. If the naive B cells come back, and we know that they are less pro-inflammatory in ways, it's a very fair question to ask. And this is true for B cell depletion and reconstitution, possibly also for T cell depletion and reconstitution. And so this field of reconstitution immunology and the potential to stop treatment and see durable effects is, I think, of great interest to explore.
So I fully agree with you, and you have some very elegant papers showing that this phenomenon absolutely exists. I guess the question is about the durable response. So with alemtuzumab, we know that it can be fairly durable. With B-cell depletion, how long do you think it will take before those B cells make the same mistake? You have immunogenetic predisposition, presumably there are drivers like Epstein-Barr virus, and so is it inevitable after you take someone off?
You know, this is a question that was raised also with bone marrow transplantation at the extreme. Now, we have much smaller numbers with BMT, but with a highly ablative BMT in younger, early, highly inflammatory patients, it appears to be durable treatment effect for many, many years thereafter, a decade and a half now, in all patients who survive the treatment. With alemtuzumab, the numbers go down to maybe 50, 60%, maybe cladribine less, and likely anti-CD20 less than that. A really interesting question is how and why do patients differ, and can we measure something early on that will predict who indeed will versus will not? Because we do know that some people in whom B cells come back will get new disease activity, but there's a general impression, certainly our Swedish colleagues who've used anti-CD20 a great deal and have had patients come off for a variety of reasons. Some of the reasons may confound. If it's pregnancy, the biology, of course, is different. But the sense is that there is less overall disease activity when people are allowed to reconstitute. We're actually doing a study launched through the NIH and the Autoimmunity Centers of Excellence that will look at a randomized discontinuation trial of anti-CD20, where everybody will start for at least 12 months and then get randomized either to go onto placebo, to continue for another 12 months for a total of 2 years on anti-CD20 and then placebo, or continue for 5 years, with the primary endpoint being a 5-year yes or no durable treatment effect. 3 monthly MRIs and blood draws, so high intensity, very close proactive follow-up to try to address is the phenomena a real phenomena, very clear stopping rules, and what is the biology that underlies.
Okay. Other thoughts? Well, you mentioned trying to have a marker for prognosis. The next thing we would want would be for a marker of response to any of the therapies, right? Because we know that patients have responded to every single therapy we've ever used. That's how the drugs got on the market. And, in that responder group are the true responders, and a penumbra of people who maybe didn't respond, but nevertheless, they're there. And so we could broaden and rationalize what we're doing if we had those markers of treatment response.